Good afternoon, all. I'm pleased to welcome you to the Introduction to Bronchiectasis webinar with Dr. Tim Aksamit, Medical Director of Bronchiectasis and NTM 360 of the COPD Foundation. My name is Christina Hunt, and I am the Director of Bronchiectasis and NTM Research and Education. I will be your moderator today. We have organized this webinar in honor of Rare Disease Day. As you may know, bronchiectasis is not currently considered a rare disease, although it is thought to affect several hundreds of thousands of individuals worldwide. Before we get started, I'd like to make an announcement regarding an exciting new initiative we're organizing. We have declared World Bronchiectasis Day to be observed annually on July 1st. World Bronchiectasis Day is being organized by an international planning committee co-chaired by Dr. Tim Aksamit, who you will hear from shortly, and Professor James Chalmers of the University of Dundee. The Global Planning Committee is comprised of patient advocates, representatives from collaborating patient advocacy organizations and professional societies, and leading experts. World Bronchiectasis Day aims to raise global awareness, share knowledge, and discuss ways to reduce the burden of bronchiectasis for patients and their families worldwide. I invite you to learn more by visiting www.worldbronchiectasisday.org. Now to get started with our program. I want to ask everyone to mute their microphones so that we can eliminate any distractions for our speaker. Once Dr. Aksamit concludes his presentation, we will open it up for a questions and answers session. This webinar is being recorded and will be made available for future viewing. And without further ado, we will begin the webinar. I want to first start out by introducing our presenter today. As mentioned, Dr. Tim Aksamit is the Medical Director of the Bronchiectasis and NTM 360. He currently serves as a consultant and associate professor of medicine at the Mayo Clinic in Rochester, Minnesota. He is triple board certified in internal, critical care, and pulmonary disease. He served as chairman of the U.S. Bronchiectasis and NTM Research Registry for many years and has been involved in and authored numerous publications regarding the treatment and identification of bronchiectasis and NTM lung disease. Welcome, Dr. Aksamit.
Thank you, Christina. And I'm going to just disclose, as Christina said, that I previously was a chair of the United States Bronchiectasis Research Registry. I've participated in many clinical trials, but I don't receive any personal or any research funding. All of those monies and support that normally goes, as part of that, goes to my employer, and that's the Mayo Foundation for Medical Research and Education. But I am very active in clinical trials, and I really appreciate all your participation and support of those clinical trials as well. Next slide. I'd like to thank all the participants for your time and extend a good afternoon to most of you. And for those international participants, a special welcome and a good morning or a good evening, depending on which side of the pond you're on. And it's just great to have you. You're an essential element and part of the movement forward, and why we're here on Rare Disease Day to actually raise awareness. This webinar is going to be on introduction to bronchiectasis. So for those of you that have bronchiectasis, this may be material that you're already familiar with. For some of you that maybe aren't so familiar with bronchiectasis, it may be a little bit more than what you're aware of. And Christina will provide additional resources and links to not only see some of this material again, but if you'd like to do a little deeper dive or to go through things another time to try to understand more, we'll share those resources with you. My experience tells me, and many of you that maybe we've talked together in the clinic understand a lot of my comments, but one of those is sometimes it takes a second or a third time to get through material before it really sinks in. So don't be hesitant to reach out, look for the resources, and even try to cover that ground 2 or 3 times if necessary. I've got the pleasure these days of being the medical director for the Foundation of the Bronchiectasis and NTM 360, which again is sponsoring, and on the next slide, World Bronchiectasis Day. And this is really a very special initiative with so many international and global partners from not only Europe, but Brazil and China, Japan, Australia, and all around the world. And again, a credit to all of you, South Africa, for supporting this. And the notion is that on every 1st of July, starting this year, July 1st, 2022, and this will be in conjunction with the World Bronchiectasis Congress, which will be the 5th World Bronchiectasis Congress held in Prague, will officially roll this out. But the goal here really is to raise global awareness, to share knowledge, and to walk together, if you will, and discuss ways that we can reduce the burden that so many of you probably are so familiar with, and your families and caregivers as well. And as this global burden really is, I think, substantial, and I'm glad that we're having the opportunity to raise awareness and walk together. Next slide. This is the site for Bronchiectasis and NTM 360 initiative with the link on the bottom, and again will be made available to you. There's a great deal of resources and great information here. And on the next slide, this is the site. And on the next slide, there are very easy links so that you can do a little deeper dive in various aspects of bronchiectasis, including airway clearance and pulmonary rehab, and things like nutrition and how to handle exacerbations. So a lot of this material that I'll cover today will be embellished on these sites and then direct you to other resources. So I can't encourage you enough to reach out, be active, be your advocate, and I think that that's the pathway to successful management. Next slide. We have a PDF and a hard copy version of the 1, 2s, and 3s. That is the basics of bronchiectasis from the Bronchiectasis and NTM 360. This is available, and Christina, I'm sure, will be able to make this available to you in either hard copy or PDF form, should you be so inclined. I share this with virtually all patients that come through our bronchiectasis clinic that I have the opportunity to meet. I think it's helpful information and helps set the stage to give an overview and a deeper dive into an understanding that would really help insofar as your management programs. Next slide. So over this next 40 minutes or so, what I'd like to do is just to cover a few topics that I think are pertinent when it comes to the introduction. And I, again, just want to emphasize, this isn't as a deep dive. We could easily spend an hour on each one of these sections or even longer, but just to give an overview to hopefully set the stage and then open the discussion at the end for a few more clarifications and to share maybe your experience with your colleagues and other participants here. And so what I'd like to do is first share a few thoughts on what is bronchiectasis, how common is it, what can you do or we do as providers about bronchiectasis, and then we'll leave a little time at the end and Christina will moderate for us and hopefully further clarify some of these areas. Next slide. Let's turn to then what is bronchiectasis. And when I think about bronchiectasis, it's important to realize that this is a disease of bronchial tubes, not the alveoli or the little air sacs themselves, but a scarring and a dilation of the bronchial tubes. With that goes an impairment or a slowing of the normal handling of the mucus we all make in our airways that normally is cleared, it comes up, we swallow it, and that is impaired by this scarring, dilated bronchial tubes. We then have retention or pooling, if you will, of mucus or secretions, and that's a great place for the germs that normally reside in our airway, and we all have germs in our airway that reflect the germs in our environment. We don't live in a bubble. We don't live in a sterile environment, and all those germs all around us, whether they're bacteria, fungi and mold, naturally occurring viruses, phages, or other atypical germs like mycobacteria, cousins of tuberculosis, are all residing in our airways. And with that pooling of mucus, we think that that's a great milieu or a place for germs to grow and then set up what's been known as a vicious cycle of infections that then cause more damage, more retention, more damage, and then more infections. And so we're going to come back to this construct or model of this vicious cycle, but really to a large extent, one of the primary goals is to prevent that pooling or retention of mucus or secretions within the airways, and we refer to that as airway clearance, and that's a topic that I'll come back and talk in more detail about in just a moment. Next slide. So what does that look like? So on the top picture, we have a normal airway, and then we, on the bottom right, have a airway that's dilated, it's scarred, and it then has this normal mucus we make, but it's retained. And that's that milieu that germs like to grow in and cause more infection, more damage, and set up that cycle. It goes around and around. And we try a lot of techniques to minimize that pooling or retention through airway clearance. And I would just share that this is a scarring, so much akin to if you were to cut your finger and get a scar on your finger. Once that scar is there, it's there for good. So what I share with patients, as many of you probably have heard from me when we're in clinic, is that when that bronchiectasis occurs, our goal is to not necessarily make this go away, because we can't make scars go away. But what we can do is to prevent it from getting worse. And we think that the primary way to do that is to prevent this pooling or retention of mucus, prevent infections, and prevent that process, that cycle from going on. So again, our goal isn't to make this go away, but to prevent progression. So abnormal but stable is our target. Next slide. And so this is just now again, a picture of this vicious cycle that we've talked about. And we can start in the lower left-hand corner of this circle with a bacterial infection that causes our bodies to have an inflammatory response to try to get rid of those germs that causes more tissue damage and more dilation, more retention of mucus, and sets that up. And we'll talk about each one of these components, how we might be able to treat that and try to break this cycle. Next slide. This slide is another construct or a more recent model proposed by Dr. Flume from South Carolina. It's a vortex rather than a vicious cycle, but it still emphasizes that there are many interrelated parts of this, and I don't want to go into great detail other than just as you look at it, it's a very complex set of relationships of what's going on in the airway, and that the infections and the germs and the mucus all have an impact on each other, and if we can try to minimize that, that should help prevent progression and help with this interdependence in relationships so that we don't have progression of disease. Next slide. How do we diagnose bronchiectasis? In most instances, it's done by a X-ray and a chest CT scan, which has much more sensitivity than a regular X-ray, although this will show up on X-rays as well. Most of you have had high-resolution chest CT scans, and that are very often associated with symptoms. The most common symptoms, as probably all of you have experienced, are cough, generally with sputum production, but not always. Fatigue is very common with this, and dyspnea, which means shortness of breath or breathlessness, hemoptysis, or sometimes coughing up blood. It may be a few flecks of blood, maybe streaks of blood, or even sometimes clots of blood. There may be sharp chest pains that go along with this bronchiectasis, and they may come and go depending on whether we're having flares or not. And then when there is more advanced disease, we often have weight loss with this. And that's the way our bodies physiologically respond to the stress of these infections and inflammation that goes along with it. Next slide. So this is the CT scanner that many of you are familiar with, and generally gives us a more sensitive and more precise picture of what these dilated bronchial tubes look like. Next slide. And this is just a couple of sections of a CT scan, and we see, and we have specific criteria in the box. I don't want to belabor that in the interest of time, but with the scarring, we oftentimes will see not only the bronchial wall thickening where this inflammation is, but where this mucus accumulates and causes plugging. And when that mucus accumulates in the very small distal airways, it sometimes fills those airways, and it causes what we call a tree and bud pattern. That is, it looks like a branch with little buds coming off, and that represents mucus being retained in the airway. And that too, just like we had looked in the central airways, we want to prevent that accumulation to minimize the likelihood of infection. Next slide. And this slide, again, is just another representation. It's a busy slide that I want to convey the image that there's a lot of moving parts of interrelation between these scarred dilated airways, and that these mucus-filled small airways, tree and bud infiltrates, and then all the other reactions that occur as a result of that. Next slide. In addition to the high-resolution CT scan, oftentimes there are other tests to help your providers understand more about the impact of bronchiectasis on your lungs, and that may involve what we call pulmonary function tests, or measuring your lung capacity and how well your airflow is in your lungs. Next slide. And that may be just a simple spirometry, blowing into a tube. We also can get an idea of the efficiency of oxygen and carbon dioxide across the lungs in what we call a diffusing capacity. And then sometimes you go into a big plastic box, essentially, to actually measure lung volumes. Because of this notion that we have retention of mucus and trying to understand what are or what are not, say, the culprit germs that are causing problems or may need to be treated, we oftentimes will collect respiratory secretions or sputum. If patients are coughing that sputum up spontaneously, it's a great way to sample to understand, are there bacteria, and if so, what kind? Are there mold or fungi present? Are there mycobacteria present? Sometimes if you're not producing a lot of sputum, we do what we call an induced sputum, which means that we have you inhale some concentrated salt solution to loosen up those secretions and allow a sampling. And that sometimes, and it says bronchiectasis, but it should have been bronchoscopy. I apologize for that. Sometimes we even have to look down into the lungs with a lighted scope to get a specimen to understand what those germs are in the airways. In most instances, if you are coughing up sputum on your own, we don't need to do the bronchoscopy. But there are instances that we find that very useful. Sometimes we'll do additional blood tests, and I'll come back to this notion, trying to identify, are there any unusual associations or causes of bronchiectasis in your particular case? That may involve looking at what we call immunoglobulins, which are proteins to help fight off infection. Alpha-1, which is a genetic predisposition to bronchiectasis and emphysema, or genetic screens, especially in younger patients, for cystic fibrosis and other genetic abnormalities, which are uncommon, or autoimmune problems, and I'll come back to that in a moment. Next slide. So how common is bronchiectasis? Is this something that we see a lot of, a small amount? We're talking about it on Rare Disease Day, so as you would gather, it's far less common than, say, high blood pressure or diabetes, or even certain types of cancer, But let's look at how common it is. Next slide. So this is taken from the 1, 2s, and 3s of bronchiectasis. There's about 25 people per 100,000. And in an older adult population that is over 74, it goes up about 10 times that to almost 300 per 100,000. And to put this in perspective, our current tuberculosis rates in the United States are about 3 per 100,000. So bronchiectasis is about 10 times that, and in an older patient, probably 100 times as common. And I'll come back to what those causes are. Next slide. The other aspect, so when we do estimates at various databases and trying to get an idea in our heads around just how much bronchiectasis is there in the U.S., we estimate that it's probably several 100,000, on the order of about 300,000 or 400,000, and this may in fact be an underestimate. The other part of this slide on the x-axis is, as we get older, you see that the frequency of bronchiectasis increases somewhat dramatically, almost exponentially, starting at about age 50 and goes up. So this is a disease that is a mostly older patients, that is of Medicare age or older. And so we understand that when we see this in young patients, and it can happen in young patients, it raises flags for more rare and genetic problems, but this is something not uncommon in our adult population. And the other aspect here is it's more common in women than in men, not because of anything that you've done and not because of any fault of yours, but it's in the US, in North America, it's more common than men. And again, you see some idea of more than age 75, that total number is about 800 per 100,000. Next slide. And this isn't just restricted to North America or the US. So this is a similar type of analysis that was done in Europe and Germany. Next slide. And you see a very similar type of bar graph. That is, as we get older and pass about age 50, the rates go up. But interestingly, there's more men than women in Germany. And again, it just, I think, speaks to this notion that all bronchiectasis globally isn't the same. And so if we were to look at groups of individuals with bronchiectasis, and if we're comparing groups in Asia or Australia or Europe with our experience in US and North America, it may or may not be similar. So there are variations, and especially when we're raising awareness globally, as this initiative is, we have to be mindful of that. But in the US, more women than men, again, by no fault of the patients, and in Europe and in Germany, more men than women. So there are differences. Next slide. And next slide. And taken from that same German analysis, and there's similar trends in the US, I didn't include that in the interest of time, but the diagnosis of bronchiectasis has increased. And so this looks at a time period from 2009 to 2017. And most of us understand that it appears that the diagnosis of bronchiectasis is increasing and has increased by about 10% per year. Now, the question is that because it's being more recognized with more CT scans? But even with that aside, most of us that do clinical investigation feel that there is an increase in bronchiectasis. So as we get older, the incidence goes up, and over time, the incidence has gone up. So it's an increasing problem and burden, not only in the US and North America, but globally. Next slide. So let's talk about the causes. First and foremost is this top bulleted item, unknown or idiopathic, which means we're not smart enough to figure out why it's there. And that accounts for, in most series, about 50% or more bronchiectasis. So very often patients ask me, well, why do I have this very difficult and chronic issue? Well, it's by no fault of yours, and we're just not smart enough yet to figure that out. but we're hopeful that we'll have a better understanding with initiatives like this World Bronchiectasis Day and all of your support to try to shed light onto that. The other group next down is post-infection after a pneumonia or tuberculosis, or if there's something called aspiration where food or liquids go into our lungs, and that accounts for probably another third. So that takes us up to about 85% of all the cases. The other issue I would also just caution you, and there used to be a lot of talk about measles and whooping cough as a kid. Some of that's true, but not a lot of it. And so I hear this story often that someone's traveling, they have respiratory symptoms, they come in to see their provider after they return home, and lo and behold, they've got bronchiectasis, and they attribute that bronchiectasis to their trip. And in fact, what I think happens in many instances is that bronchiectasis has been there for a period of time. Not a lifetime, not even maybe 10 or 20 years, but maybe a year or two or more. And then they go on their trip and they get a viral illness or they pick up a cold. And then that cold raises awareness and brings individuals to their providers to look things over. And then lo and behold, they say, aha, there's something here in the bronchiectasis, which likely was present before that. It wasn't symptomatic enough to bring it to attention of yourself or your providers. So I can't tell you that it can't happen that an illness that occurs on a trip is the cause, but in most instances, it's really the trigger that raises awareness. So that again accounts for about 85, maybe even up to 90% of all the bronchiectasis, which leaves that last 10%. And as we talked about, sometimes when individuals have immune problems, if they have a low protein level that fights off infections, we call that hypogammaglobulinemia, long fancy term of just saying that you have a low protein and that we can replace that. Doesn't happen often, but it can, and we oftentimes will do a blood test to screen for that once bronchiectasis is identified, or especially in younger patients, we look for genetic predispositions, things like cystic fibrosis and something called primary ciliary dyskinesia, which means that the little hair-like structures in our airways are affected by genetic abnormalities and predisposed to more retention of mucus, more infections and problems. I might just, as an aside, spend a moment on cystic fibrosis. We typically think about that in young individuals, that often kids with cystic fibrosis, they're having trouble even maybe in their young teenage years or before. And then as they go on, they oftentimes then will have very advanced bronchiectasis. What we've come to appreciate is that we're finding more and more adults with what we call adult diagnosed cystic fibrosis. And now there are therapies. We don't know yet exactly what the best application or role is, but there are potential therapies that may be of benefit, and there are ongoing clinical investigations to try to understand, can we use some of those therapies that the kids with cystic fibrosis that we can use in our adults that have less severe presentations, but have some genetic markers that are consistent with cystic fibrosis. So it is something that if you do see your provider and he or she wants to do some testing, I would encourage you to have that, because there are potential options that may be of benefit here. Next slide. The other thing that I would like to, or aspect I'd like to emphasize, is that bronchiectasis oftentimes doesn't happen in a vacuum. There are other conditions that this is also present with. One is COPD, which is chronic obstructive pulmonary disease, and I'm going to come back to that in a moment, so I'm going to pass by that, but asthma, or sometimes inflammatory conditions in the body, autoimmune problems. There are certain things with called connective tissue disease or Sjogren's scleroderma, but they're autoimmune problems. Sometimes certain types of inflammatory arthritis like rheumatoid arthritis, or inflammation in the bowel, inflammatory bowel disease like Crohn's disease or ulcerative colitis can be associated with the same sort of inflammatory change in the lungs. And if those are present, we need to address those as well. For patients that have a separate process in their lungs of scarring, pulmonary fibrosis. Oftentimes with that damage from the fibrosis, they get bronchiectasis, but it's not that same type of bronchiectasis that we get with primary dilation of the airways. And then for those that maybe needed radiation for a cancer, whether it's a lymphoma or a breast cancer, sometimes there's lung damage that then can cause changes within the airway of bronchiectasis. Next slide. There are associated conditions of reflux disease. You'll hear the term GERD or gastroesophageal reflux disease. Sometimes you'll hear people talk about hiatal hernia, reflux, or esophageal dysmotility. And esophageal is just the swallowing tube from the mouth to the stomach. And that sometimes there are problems with swallowing that will not only exacerbate lung problems, but actually can cause problems, including bronchiectasis. So we generally have a very aggressive approach to make sure that's not a contributing factor. In those instances that it is, we can give you medicines by the carload for your lungs, and we won't get on top of things until that swallowing or reflux is taken care of. And in a similar fashion, we understand that there's a group of individuals that may have sinus problems that go along, sinus infections and problems. And when there's untreated sinus infections, that too will be something that, as long as that's there, it'll be very difficult to get control of the lower airway symptoms. And then lastly, there are specific lung infections, cousins of tuberculosis called non-tuberculous mycobacteria, MAC or M. abscessus, that many of you have. In the interest of time, we won't go into that today, but it's another one of the many germs that can affect the airways and the lungs, and sometimes needs to be treated in addition to the bronchiectasis. And then there's fungi or mold, including things like Aspergillus or Cedosporium, and these are all organisms that are all around our environment. Nothing that, again, by any fault of anyone, not whether you're in a clean house, dirty house, they're just everywhere in our environment. Next. I do want to just spend a moment on COPD, because this is something that's, I think, very commonly encountered. And again, COPD generally refers to chronic obstructive lung disease. We generally think about that in terms of smoking-related lung disease, but it's also been known to be with exposure to smog, pollution, biomass fuels in other parts of the world. But bronchiectasis is not COPD. Bronchiectasis is separate. Nonetheless, oftentimes people are labeled with bronchiectasis for sometimes months or years incorrectly before the bronchiectasis is noted, and it would delay a diagnosis of bronchiectasis. And just to emphasize again, bronchiectasis is not associated with smoking, whether it's firsthand or secondhand smoke use, but bronchiectasis can occur with COPD and overlap. The next slide. So when I think about bronchiectasis, it's the third most common of the diseases that affect the airway. The others are asthma and COPD. Next slide. And so the way I think about this in kind of construct terms is there in Venn diagrams, there's overlap because there are similarities that they both affect the airways, but in different ways. So one can have COPD alone, one can have bronchiectasis alone, or one may have both. And when they're both present, both need to be addressed and treated. Next. And this is just gives you a representation. On the x-axis are different types of etiologies, starting with the most common, idiopathic, or we're not smart enough to figure out why, and then post-infectious, immune problems. And then we have a representation based on the colors, as you see, from high-income and low-income countries, from different continents, Europe, North America, South America, Africa, Asia, Australia. So you can understand that there's a difference in distribution, and we just need to be mindful. And as we raise awareness globally, again, how we view bronchiectasis here in the US and North America may be different than Africa or Europe, South America or Asia or Australia, and we just need to be mindful of that. Okay, next slide. And that raises, again, or brings us to this World Bronchiectasis Day. And as we work together on this pathway, there are some very similar things that happen no matter where we are in the world. But there are also differences, and we need to be mindful. And if we pool our resources and walk that path together, we're very encouraged that we'll be able to make more progress. Next slide. So what can you do? When you do have this diagnosis of bronchiectasis, and this is something that all of you, well, most of you wrestle with a lot. Let's go to the next slide. And I would first start out and say that bronchiectasis is manageable. It is treatable. It's not to be dismissed and say, oh, I can't do anything about this. Yes, it can be. And what I oftentimes tell patients is what works for one patient won't work for another patient, and it has to be individualized. So we need to find what works for you. And sometimes when you talk amongst each other, you might say, this is the best thing that came along since sliced bread. This is great. And then you try it, it doesn't work, and vice versa. So it has to be individualized, but this is manageable. And I think all of you, you're here. This is absolutely fantastic as we walk together through education, through your own advocacy, and empowerment is the way to have successful treatment, but it is manageable. Next. And that the best bronchiectasis treatment is the treatment that works for you and that you can use it. If it doesn't work for you or you don't like it, that's not the best treatment for you. And again, we have to individualize that. Next. So it brings us back to our model of this vicious cycle of talking about this pooling of retention of mucus in the airways, more infections, more damage, and then more problems with mucus clearance. Next. So let's talk about airway clearance. And that was, I think, posted in the chat room. And it's, as pointed out, really the kind of essence, or at least the starting point of all successful treatment of bronchiectasis, is to prevent that pooling or retention of secretions to minimize the effects within the lungs. Next slide. So again, just thinking about the model, we have normal airways, and our bronchiectasis airways are scarred, dilated with this retention, pooling of mucus in the airways. We need to clear that out. So what are our options for airway clearance? And these are discussions you need to have with your providers, maybe in pulmonary rehab, with respiratory therapy, with other nurses. And then there's lots of resources on the NTM or bronchiectasis and NTM 360 site, and we'll be able to share those with you. Next. So the way, again, I think about this is an airway problem, not a little airway sac problem. And with those airways, we get a scarred, dilated airways. We get retention of this mucus and the damage of the cilia, and that's where the infections are. And we spend a lot of time trying to keep that airway clear. That is, get rid of that mucus. And if we're successful, next slide, we're left with a scarred airway, but not a retention or pooling of, so less likely to have infection, or we break that cycle. Doesn't mean that the bronchiectasis is gone. The scarring's still there. It'll show up on an X-ray or a CT scan, but we're preventing progression rather than making it go away. Next slide. There's great resources that help us, and as we're going to talk about different options for airway clearance, and of course on our site, you just very easily accessible. Next. There are other, this is taken from the Australian site, a bronchiectasis toolbox, some very helpful videos and other thoughts to explore. Next. And so let's talk about airway clearance. And again, I just would emphasize that, in my opinion, it's the cornerstone to successful management. And so I think about this as a spectrum of options. And we start with the simple, easy things first. And regular aerobic activity is clearly important. We got to keep all of you moving. This is imperative. Regular aerobic activity will help clear mucus from the lungs. That's great. And it's certainly fantastic for lungs. But from a wellness standpoint, whether it's women's health or men's health, it's great for your overall wellness to be moving. It's great for bone health, stress management, balance, strength, cardiovascular risk management. And what that looks like, we're not training for the Olympics, so we're not wearing necessarily spandex and intense training. Most of my patients walk, but whether you ride a bike, do an elliptical, ski machine, or do yoga or Tai Chi, as long as you're doing regular aerobic activity, swimming, all of those are helpful in this way. To put this in perspective, for the young kids that have cystic fibrosis and advanced bronchiectasis, and they're in school, whether it's grade school, high school, college, and if they're doing any kind of sports, that on the days they do their athletic training and all their conditioning, that might replace some of their lung treatments, their nebulizers and all that, because they're working so hard. So again, as a starting position, I think it's imperative that we all keep moving, whatever that looks like for each one of us. And again, I say that with activity. I even hesitate to use the term exercise because we want you just to be moving. Next thing that we try is deep breathing. And sometimes it's a very formal assessment of active cycle breathing, where I'll show you in a moment, kind of in a very specific. Otherwise, deep breathing, whether it's part of yoga or other types of breathing techniques, can be very, very effective. Postural drainage, certain positions, and I'll show with or without sometimes a partner or someone kind of clapping on our chest, trying to loosen up that mucus. Sometimes there's certain positions that work really well for patients, and other patients say, I try it, nothing happens, in which case we're not going to stay with it. There's something called PEP valves, positive expiratory valves, which we blow against. The beauty there is that there aren't any medicines, there's no side effects. It sends vibrations into the lungs as we exhale. There's lots of different products out there, Aerobic, Flute, Acapella, Flutter, and there's lots of others that many of you have tried and can be very effective. And again, the beauty is that there's no side effects. So you could use it once or 100 times a day. Most patients will use them once or twice a day, oftentimes in conjunction with your other measures. If it doesn't help and you've tried it and it doesn't work, I'd much rather have you spend the time on the things that do work. Stay active, walk, ride the bike, do your breathing exercises otherwise. Hypertonic saline, really important to help try to loosen up secretions in some instances. So that's usually by a nebulizer after we do an inhaler or a bronchodilator. Our normal salt concentration in our body is 0.9%. And so we then will nebulize a 3% salt, no medicine, just salt water, concentrated salt, to try to bring moisture into the airway, loosen that thick, sticky mucus up so it's easier to cough out, 3 or 7%. The kids with cystic fibrosis universally use 7%. Many of our adults that don't have cystic fibrosis with bronchiectasis will start out at 3%, but there's no reason why you can't try 7% if you can tolerate it and doesn't cause too much cough. And then lastly, there's something called the high frequency chest wall oscillation. It's a vest type issue that then shakes the chest. There are several different commercially available products out there that one can try to see if that does seem to help. But again, this has to be individualized. There you go. We have a participant holding up his vest. Fantastic, absolutely. And in some instances, incredibly helpful. I have other patients, adults, that have their vest, and it's a little too much. And sometimes, whether you have some osteoporosis or other types of chest wall, there's not a right or a wrong, and there's all kinds of different products to work with your providers to get. And there are some that you can walk around the house or the office, in the case of our participant, kind of illustrating using it. So they don't necessarily tie you down in any way, and sometimes it's worth a try. But again, like all of this other, we have to individualize this. We have to find what works for you. And if you try something, you don't like it, it's too much, then we'll use something else. Next. This is just capturing this active cycle breathing, deep breathing, a very just specific way that your providers will give you information. And you can do this kind of active cycle breathing while wearing your vest. There's no reason why you can't combine this or do this sequentially. Next. This is just one of the many positive expiratory pressures, blow against. There's not any medicine involved, so there's no side effects. But if you're not finding benefit, my bias is don't waste your time. Do the things that do help, whether it's vest or exercise at a minimum. Some of these, like this product, is made so that you can do a nebulizer while you're doing the PEP valve. Next. This is postural drainage. There are some positions that some patients will say this really works. Oftentimes you kind of gravitate to this and patients say, I just found when over the years, this really seems to work best in certain positions. And when you're in these positions to do your deep breathing, to do the PEP valve or the nebulized hypertonic saline, trying to mobilize that area of the lungs. And again, this all varies from patient to patient. Next. And this is just a picture of looking at nebulized hypertonic saline and its impact on the surface of the airways. And it just illustrates that we do, in fact, with hypertonic saline, change what that mucus looks like and how those cells interface with that on the surface of the airway. And so, and again, in some instances can be very, very effective. But the best therapy, just to answer the question, is the one that works for you and is tolerated. I see in the chat someone says that if bronchiectasis is airway dilation, why do we use bronchodilators? So bronchodilators aren't always used. Bronchodilators are used for asthma. We think that it may help facilitate moving this mucus, but we also think that bronchodilators, oftentimes given before things like hypertonic saline, may help decrease the incidence of cough. So it sometimes will make the treatments more helpful. And next question, what should we do during a nebulizer? Should occur when doing a nebulizer and vest? What are you referring to? Do what helps. Yeah, so again, this is and really what I'm trying to, I think, emphasize is that this has to be a trial and error basis. And that there's not an easy way or a priori for any of us as providers to say, this is what's going to work for you, whether it's the postural drainage, whether it's the nebulized hypertonic saline, the PEP valve, the vest, but we try things one at a time, and that to try to then go through that sequentially to sort that out, because we don't want to dismiss or deny something that's going to be very effective. The only thing I really insist for all patients is you stay active. We got to keep you moving. That's at a minimum. Next. And then this is a picture of a vest as one of our participants had been put on during our presentation here. And they're oftentimes very easy to get in, get out. Some are very portable. And again, several commercially available products out there that you can talk to your providers about how to best try those. Next. So let's talk about antibiotics. And again, this is another area that is very common for those of you who have had bronchiectasis. Next. And this picture just emphasizes that as bronchiectasis goes on, we don't really change the amount of organisms that are in our airway, but the diversity or the spread of different organisms decreases, and that certain bacteria or other organisms kind of outgrow everything else. And so very often then that's our targets, and if we need antibiotics, we go after kind of the bad organism in the neighborhood, if you will, to try to tap that down and let the other organisms, which are, again, a whole panoplia of different organisms, available. Next. And so this is all offset, of course, by not using antibiotics if we don't have to. So there's a certain interest, and a great deal of interest, nationally and internationally, to not overuse antibiotics. So we want to find the right antibiotic at the right time to minimize toxicity and then to minimize the likelihood of infection. So if you need antibiotics, it's a great thing, can be very, very helpful, but we also don't want to overuse antibiotics because the more we use them, the more resistance will develop. And let's go to the next slide. And this just captures that antibiotic resistant organisms account for a lot of morbidity and even mortality in the US. So it comes at a cost, and we want to be very careful about using antibiotics. Not be afraid, not to not use antibiotics, but only use antibiotics if we need to. Next. And this is just a picture showing over this last 20, 30 years, how much resistance there have been with some organisms. And that's been attributed to a large extent, the increased use of antibiotics, which are, again, all well intended, but we also understand that the more we use antibiotics, the more resistance we'll have. Next. And there are guidelines. This is just one example taken from the Europeans. Next. About trying to give us guidance about when to use antibiotics, whether it's oral antibiotics or inhaled antibiotics. And again, when there are symptoms and we're having frequent flares or exacerbations. Next slide. And there's very specific definition, that is, of having symptoms of cough or increased sputum and darkness, having more shortness of breath, coughing up blood, having more tiredness, combination of having these flares, or what we call exacerbations. So we need to be able to respond to that when the need arises, and very often involves collecting sputum, trying to understand what the germ or germs are that need to be targeted in this way. So I don't want to leave you with the impression that antibiotics shouldn't be used. They should, but we should be responsible stewards. Next. And then just to leave on a couple of last parts of this cycle. First of all, corticosteroids or prednisone, we generally do not use unless there's a reason, because you have asthma or COPD that need to use steroids. We stay away from that. And then the macrolides we do use, and that's the Z-Pak type erythromycin. Next slide. And that there have been 3 large studies approximately 10 years ago that have all showed benefit. Next slide. And this looks at just rate of exacerbations or flares with the use of macrolides, so that it does have a positive impact. The problem that we have to offset that with is resistance of organisms, and then worry about other infections. So in select instances, it can be very effective therapy, but we also want to be certain that that's the right therapy for you. Next slide. And then I'll leave with bronchodilators. And again, as we had said, that if there's a reason to use those either before hypertonic saline or if there's asthma, we use those, generally well tolerated. And then just as an aside, if that bronchiectasis, that scarring of the airway, is restricted to just one area of the lung, nowhere else, and continues to cause symptoms, occasionally and in rare instances, we recommend take that abnormal lung out or surgically remove that. Next. And then there's lots of other aspects of bronchiectasis that so many of you are so mindful of. We have to pay attention to our nutrition, and that's a discussion they have with your providers. Frequent small meals, make sure you're eating enough, getting enough calories, getting enough protein. Unintentional weight loss is not our friend. We spend a lot of time when we're young trying to keep our weight down. This is not the time to do it. Be kind to yourself. I'd rather have you a little bit above your ideal body weight than below. Not that we want you big or excessive. Exercise, keep moving. Sometimes that's part of a formal pulmonary rehab program, which can be very effective as well, but keep moving. Obviously, don't smoke, but as I said, almost all of bronchiectasis, at least in the US, is not smoking related, first or second hand. Keep your vaccinations up with your pneumonia shots, with your flu shots. And then keep your appointments if you have questions about all of this. And I might, just as an aside, and I purposefully left off COVID just because we're so overwhelmed by all of this. And I'll just share with you that the recommendations with respect to COVID are no different than the general population. There isn't probably an increased risk if there was an infection, but it's not nearly what it is for other individuals with immune problems. So most patients should do well if they were to get this. We would recommend to be vaccinated, especially in our adult population. We think it does help mitigate risk, but that's, again, a discussion to have with your providers. Next. This is a summary, and this is a patient-centered research priority map, and I just wanted to include this just to emphasize how important it is for all of you to continue to participate, to support, to advocate. And this was came out of a group hosted by the Portland group, OHSU, Health Sciences University in Portland, Oregon. And again, patient perspectives are really critical to us understanding what the needs are. And so I can't emphasize enough how dependent we are for this and really have brought us here. We had a conversation just before we got started with one of your colleagues that was here. We've been at this 8 or 9 years, and we've made great deals of progress with a lot more room to go, but we really need to have your continued advocacy. And we do hear what you're saying, and that with a reference like this, helps capture and put things in context and perspective for all of us who are interested in trying to move this forward. Next. So in summary, what I would say is that bronchiectasis, when it's diagnosed, is manageable, but what works for one patient won't necessarily work for all patients. So we have to individualize, find what works best for you. The prevalence of bronchiectasis is increasing worldwide, not just in the US and North America or in Europe, but everywhere. Be attentive to airway clearance. Find out what works for you on your schedule, with your activity, what you may or may not be able to tolerate. And then if you need antibiotics, use them and talk to your providers about it. But if you don't, hold off. Treat if there's underlying conditions like reflux disease or sinus disease or other diseases. Those need to be treated, because if those are driving or contributing, we can give you, again, medicines by the carload for your lungs. We're never going to get on top of that. And just to belabor this just for a last moment, that your education, your advocacy, and your empowerment are really the key, not only for successful management of yourself, but to help all of us move forward on this path together. And with that, I'm going to close, and I think we'll have a chance maybe for a few questions. But I appreciate all your time, and thank you for all your support and attention. And we'll leave you with some information about additional resources. Christina, I'll turn it back over to you. Thank you.
Thank you, Dr. Aksamit. Excellent presentation. We do have lots of questions in the chat section of the webinar. We may not be able to get to all of these today, but because I know we're getting close to our time, but let's see if we can answer just a few of those. One of the questions was, when do you think we will have an adult bronchiectasis guidelines in the U.S.?
Very soon. So this has been something that's been, and I'll share with you, many of you who know me, it's been a fly in my ointment for a number of years, and it's under active development as we talk. So my hope is soon.
Another question. When I was diagnosed with MAC and bronchiectasis, I was told not to swim because of MAC in the water. What are your thoughts?
Yeah, so that's a great question. So the issue is, again, we have germs all around us. When it comes to these non-tuberculous mycobacterial infections, we think soil and water are culprits. There's some information that suggests that water sources may be contributing. There are other data that suggest that swimming is not a problem. Where we do start to draw the line is that we think that hot tub spas, dry and wet spas, are out. But if you have an ocean, lake, river, not a problem in any way. But from a swimming standpoint, there's conflicting data whether or not to swim. Personally, I still, if that's important to you, I think swimming is okay, but no hot tubs, no saunas, in my opinion. I'd much rather, and if you have other activities that you can do, I think that's great. But if swimming is really what's close to your heart and it's the way that you find your activity, I would do it.
Another question is there any data on doing airway clearance once a day versus twice a day?
Yeah, so yes is the short answer. And the question is, again, what works for an individual patient? So very often my approach for patients is we'll start out at twice a day, and once symptoms get under control and you're doing well, if you're in a moment where you have a lot of activity outdoors, you're doing a lot of aerobic activity, maybe to cut back to once a day. And then likewise, if there's a flare, an exacerbation, or you're less active, to do that to twice a day, or maybe even go up to a third time a day, so that you can escalate or de-escalate depending on what your circumstances are, how your symptoms are. And then my experience, most of patients, you know yourself better than we do, in the sense of, are you in a good spot or not? And there's no reason why you can't self-regulate that. So I would oftentimes start at twice a day. I think more than that regularly is not sustainable. That's a lot of time and effort, because all you're going to be doing is bronchial hygiene all day long and airway clearance. And so, and if you're active, maybe cut back to once a day and see how that goes. And if that's not enough to keep on top of the secretions, then back up to twice a day.
Okay, and one last question. Given the association you described and the similarity of some of the treatable symptoms sputum between COPD and bronchiectasis, do you think that airway clearance therapy and the devices that facilitate airway clearance should be integrated integrated earlier for moderate and severe cases of COPD?
The short answer is yes, especially if it's someone with COPD and producing sputum. So sputum runs the risk if left pooling in the airways with COPD alone, no bronchiectasis, at least not yet. If it sits there, those germs will be there and it potentially can cause harm. So there's increasing evidence to suggest that mobilization or airway clearance, it can be effective and needed for COPD patients that are producing sputum, for sure.
Wonderful. Well, I think we're running over by a few minutes, Dr. Aksamit, so we're going to close out, but we'd like to thank definitely you, Dr. Aksamit, for presenting today. We'd like to thank everyone for joining us. If you have any unanswered questions, I invite you to visit Bronch and NTM 360 Social and post your questions there. Our community loves to engage and provide support to those who wish to learn more about their diagnosis. Thank you, everybody, for joining us.
Thank you.
All right. See you later.